Hello, everyone. Good afternoon. This is Dr. Khan, Executive Plastic Surgery. A warm welcome to all of our new members. It's a pleasure to discuss what is a very hot topic and a real problem, as you will see, a real problem with a real solution, if you will. And so what I want to do is I want to go ahead and answer any questions that you may have. I have my Monday morning and afternoon clinic where I see a lot of patients literally that come to me from all walks of life. I just ended up seeing a patient that had her implants done in Korea, South Korea, and she's going to be getting her explant all the way. She comes to me from the state of Washington. Today I saw another lady. She had a breast reduction with very bad scars around the nipple areola complex, up and down lollipop anchor incisions and incisions in the crease that were extremely hypertrophied, and that also there was hypopigmentation that was present, and a very dissatisfied, unhappy. She had loss of sensation around her nipple, and she had no augmentation and no the implants that needed to be removed, but she was extremely unhappy. A young lady that had her breast reduction done, and so she had complications from that surgery, and these certainly can occur in any patient. So this is the homework when one gets a cut around the nipple areola and a lollipop anchor incision. There's a lot of hurt. Now there's a lot of evidence in literature that's coming out that talks about fat grafting. Very popular these days. A lot of explant surgeons are doing, and I'm going to go ahead and do a video just on this alone. Fat grafting, long-term implications behind. And I was reading a article where almost 16% of the patients who have fat grafting to the breast tissue in order to add volume, you see these patients, 16%, that is 1 out of 6 roughly, will end up getting what are radiographic problems on mammography or ultrasound, where there might be some lesions that might look suspicious. And now you need to do further workup, an MRI or a biopsy or frequent follow-up, because there's concern for potential malignancy. Remember, 1 out of 8 or 9 women will get breast cancer. And now if you feel a palpable mass or an irregularity, you see that there are changes as a result of the fat grafting. There are pins and needle sensation, altered sensation, and 16% of the patient, as I mentioned again, have radiographic evidence of what are abnormalities that now lead to more workup and more follow-up at the breast center with concerns for ruling out malignancy. Now, I just want to go ahead and highlight, and again, these are the recommendations made here that I read last week. If I may highlight, breast implants, certain labeling recommendations to improve patient communication. So the FDA basically put out, and we will have this on our website as well, on our Facebook page and YouTube. These are the discussions that the Facebook has had, the FDA has had, that we're going to put on Facebook. The FDA is telling the surgeons that if you ever do discuss with your prospective patients who are going to get implants, that what are the implications behind, what are the long-term ill effects of getting implants. And you will see on page 13, and again, not my words, not my recommendation. I didn't write this. This is a recommendation from the FDA, where you have patient initials. It says that the patient is initializing before she's getting her augmentation, that the surgeon did discuss with her what are the effects of getting the implants. And it says, quote, "I understand that some patients who have received breast implants have reported a variety of systemic symptoms, including joint pain, fatigue, rash, memory loss, and brain fog, that some patients have called breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with the removal of their implants and surrounding scar tissue capsule. However, not all patients may experience improvement in their symptoms." This is a big deal. So they're saying that breast implant illness exists. How many times have I talked to a patient that they went to their local plastic surgeon, or they even traveled to one who said breast implant illness doesn't exist? Guess what? The FDA is telling you it does exist in this paragraph. And it says researchers are working to better understand the possible link between breast implants and these symptoms. And I'll tell you that research will continue on for another century because everything is unfortunately downplayed. I also understand that some patients with breast implants have reported health problems in their children after birth or breastfeeding. And now this is a separate issue, but this is what, again, not my words. I did not type this. And so they ask you patient initials. And I'm going to go out in the interest of time. It mentions over here, I understand that breast implants, that a breast implant is not a lifetime device. And the longer I have my implants, the more likely I am to experience a complication and the more likely I am to require a reoperation requiring the replacement or removal of my breast implant. As many as 20% of the women who receive breast implants for augmentation have to have their implants removed within 8 to 10 years. Now this is eventually because they're not lifetime devices and they last 10 to 15 years, some sooner, some later. Look, I had a 78-year-old lady that came to me. She had relatively hard implants that she got in 1982. And her time is up because she's not comfortable. There is a possibility that she very, very, very likely has bilateral rupture because they are so old. You will see, and I want each one of you to read this because this should not come as a surprise. This is what they want you to initialize. So if a young college student, 22 years of age, wants to get silicone implants, she's going to have to, as recommended by the FDA, to initialize over here that your surgeon actively discussed that these are the potential problems. Now, the other thing I want to highlight here is, next, I understand that silicone, and quote, not my words again, this is page 14. I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph node under the arms, and organs, liver, lungs, where it may not be possible to remove. Again, this is relatively, I use the word scary just to listen. They're telling you that it can happen. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. So if you ask me, just hearing that line, and where 1 out of 8 or 9 women are going to get breast cancer, and someone has implants that are going to interfere with her mammography and the delay in the pickup of breast cancer, that is wrong. That in itself should be a reason to not get an implant, in my eyes, because I don't want to miss breast cancer. I don't want the breast cancer stage 2 or 3. If I want it to be picked up, I want it to be stage 1 without the implants getting in the way. So this nice lady that I just saw, grade 3 capsular contracture, where the implants are hard, and now she's not going to be able to do a palpation of the breast tissue on once per month to look up for what is breast cancer or not. So the most common way breast cancer is picked up is a self-monthly breast exam. And right up there is mammography, where mammograms are done that pick up on microcalcifications, irregularities that may precipitate from the screening mammogram to a diagnostic mammogram, maybe ultrasound, maybe MRI, and certainly a biopsy in order to conclude what type, if there is breast cancer or not. And remember, it requires a workup. So now they're telling you that a mammogram is going to be affected. How many ladies have I talked to who chose not to get a mammogram because they were afraid that the implant was going to get ruptured, or they were going to get hurt, or it was going to be a painful process? And how many of them, their breast exam is altered? And quote, it says, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implants to rupture or leak. So this is pretty scary in a sense that 1 out of 8 or 9 women are going to get breast cancer, but they cannot get effective screening because they're not able to palpate for the breast mass, and they're not able to get effective screening of breast cancer using mammography. The next thing I want to mention here is I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants. Even if the implant is intact and not ruptured or leaking, a list of the component chemicals and heavy metal is available in the patient information booklet brochure. And as you will see, if you go to the next page, they mention over here, the different chemicals, i.e. heavy metals that the implants are made up of, like we discussed, heavy metals found in breast implants: antimony, arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead. This is on page 18. Magnesium, mercury, molybdenum, nickel, platinum, selenium, silver, tin, titanium, vanadium, and zinc. Now, the other thing I want to mention here is, and this is also very important, I want you to read through it. It is a total of, if you will, 19 pages. And this is what, again, should not come as a surprise, because your plastic surgeon is going to have you initialize patient initials. Patient initials, that means the surgeon is discussing with you, not their medical assistant or office manager. The surgeon is discussing with you. And then over here, this is also very important. I understand that breast augmentation may result in permanent changes to my breast tissue, and if my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of my breasts, including but not limited to dimpling, chest wall concavity, puckering, sagging, or different incision size or location. Now, this is where I'm talking to a patient. Her surgeon was overseas, what I would call not the best surgeon, suboptimal placement. If you look at her results, the right side was certainly very different, drooping, bottoming out, implants, very large implants for her chest width. The surgeon violated the inframammary crease ligament at the bottom, and now the breast tissue is drooping. And as you will see, if there is, quote, lack of a better word, butchering at the initial surgery, and unfortunately we see this all the time, where the board certified or the non-board certified surgeon is doing what is inaccurate, technically deficient surgery. The burden lies on me now to try to fix that problem. Now, it is very analogous to say if someone comes in with a third degree burn, where it's down to the subcutaneous tissue and the whole hand is burned or the face is burned. When I get done with the surgery, I'm not going to make that, or any surgeon is going to make that patient look like he was before the injury, right? We want function, we want aesthetics, we want to be able to get that patient's physiology and certainly aesthetics back to where she was and he wasn't. But they're telling you, if there's a lot of cut. Now, a patient that came to me today who had that nerve loss because the surgeon cut around the nipple areola and then cut all the way down and literally splayed open the breast when the breast reduction was done, you will see her tissue is not going to be the same as someone who had a inframammary crease incision and the surgeon stayed away from the entire breast tissue and was always below the muscle, putting in the implant below. So that patient has had the disservice as a result of the poor choice of making these cuts, in my opinion, if you will. And so this is, getting implant surgery is not a very simple decision. This is where you have to, as a patient, know all of these risk factors, and your surgeon must sit down and initialize and say that, okay, I discussed this with you, so that it should not come as a surprise, or what are the implications about getting implants. And again, this is very similar to getting a gallbladder removed or a knee replacement. You need to know what you are signing up for, so you know what are the long-term ill effects of getting these implants. Now, they mention how frequently you need to be getting the MRI. So if you look at the FDA guidelines, this was from 2020, document issued on September 29, 2020. Now, this is a publication from Mentor, their advertisement at the top, and if you read the fine print, they say MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. According to their guidelines by the FDA, they're mentioning, and I'm going to look at it so I can show you exactly. Remember, these are not my words. Rupture screening recommendations, quote, For asymptomatic patients, the first ultrasound or magnetic resonance imaging should be performed at 5 to 6 years postoperatively, then every 2 to 3 years thereafter. For symptomatic patients or patients with ultrasound results from rupture at any time postoperatively, an MRI is recommended. So they're saying the MRI is better, but in reality, who does get an MRI that often? Does the insurance approve it? They tell you it is unfortunately a burden on you. Now, please go ahead and ask me any questions you may have so that I can answer them. And Mar, if you can be on the lookout as well. Now, I just want to mention another patient came to me, and this was over the weekend. She had an itch. Now, it turns out, what are the reasons for an itch? Number one, you don't want to look at answers from the other perspective or previous patients of mine or other patients from another group. Because remember, the patients do not know if you had a ruptured implant. So if someone has a ruptured implant that was 600 cc's that I saw today, and she has itchiness, it's that the skin is retracting. There was a lot of inflammation. So by definition, just like when someone gives birth to twins, her skin is, quote, recoiling. She's going to have some itchiness because the skin is, quote, elastic and it's settling down. So that may be a reason for an itch. Someone can get a rash. Someone has not taken a shower for 6 days will 100% be very itchy. Not all of them, right? That in itself may be causing the itchiness. Someone may have a rash. Someone may have the itch as a result of the dilated, inflamed veins that the patients have as a result of the inflammation. Now remember, in majority of the patients, the tissue on the chest breast area is angry, irritated. You can see the dilated veins. You can see the irritation that's present directly on top of the chest breast area. Sometimes you have inflammation changes in the lymph nodes. Look, they're telling you there might be microscopic, and not in all, in some patients. So we know from the pathology report that there is histocytic reaction, giant cell reaction, non-polarizable material consistent with silica that the body is reacting to. And certainly just like you have a bad mosquito bite with swelling, and swelling here, you have irritation and itch for the histiocytes.
I have a question.
Yes,
From
please.
TikTok. What are the symptoms of leaving the capsule in?
So, very good question. So, in those patients where the capsule was left behind, not all, these patients did not improve completely. So last week I had a patient, let me use her as an example. And the many patients that I've taken care of where I have done a residual capsule, the patients have a certain number of complaints of breast implant illness symptoms, from brain fog, fatigue, joint pain, whatnot else, and they don't feel normal or well. These are young ladies in their 30s and 40s. And the capsule was left behind. The patients don't recover completely. And now when I remove the residual capsule, because I'm fixated into removing the capsule, and in my practice, what I do is I remove the fascia of the intercostal muscle, the fascia of the pectoralis minor, the fascia of the serratus anterior muscle, the perichondrium, periosteum, anything inflamed, irregular, I remove. So only good, healthy, viable tissue remains behind. We see the patients symptomatically improve. Go ahead and look at that German patient that came in and she had to have residual capsules removed because her 2 other surgeons from Europe could not remove the whole capsule. Look at the pathology report in itself that says there is silica particles embedded within the capsule. So we have this anecdotal evidence where these patients, when their capsule is completely removed, second time around, where the first surgeon did not believe into removing the capsules completely, or they cauterized the capsule thinking that was good enough because the capsule was so thin, and they continued to have these symptoms linger on. These patients now seek answers because they know that they're still continuing to hurt. And sometimes the anecdotal evidence is that 2-3 week period that they felt remarkably improved. And they felt like, wow, my surgeon took it all out. Then the symptoms hit them. Sometimes they feel as if they still have implants. Sometimes they feel that their symptoms are worse. So last week I had a physician that came to me from Arizona. She already had her explant done. She sought her surgeon out. Her surgeon believed supposedly in the BII, breast implant illness, and he said, I'm up to the task. Now I read the operative note. The surgeon said the capsule was so thin on top of that rib that the surgeon said in the operative record that he decided to leave the capsule behind because of the risk for pneumothorax, or the air in the lung. And this is a surgery where 9 out of 10 surgeons, if not all 10, don't want to even remove or think about removing the capsule. First of all, they don't want to even utter the word breast implant on us. So you will see leaving the capsule behind leaves the burden behind, and now the patients are seeking answers because they're continuing to hurt as if they have implants. And so in my practice, I say, do it right, do it once, and do it very definitively, and do it with a pure heart, with honesty and integrity, that all of that capsule is removed. So in the last year and a half, I have had 3 patients where their CD30 was positive. Guess what? The whole capsule has been removed, which is the standard of care, that if someone is CD30 positive, the capsule is already gone. I don't give that patient a chance to say I did not improve because I'm removing the whole capsule. And in my eyes, the surgery is not done in an hour and a half or an hour and 12 minutes, which is how long that surgeon took, that lady from Arizona that came. I take 4 hours plus minus on average. So I book everyone for 4 hours so that when I do the surgery, I do it where the blood loss is less than 5 cc's in well over 99.7% of the patient, 99.7% of the patients. I don't use the drains. Most of the patients do not need that unnecessary lift cutting around the nipple areola and down. The patients have the videos and the pictures showing complete removal of the capsule. The capsules are always sent to pathology to make sure that the entire CD30 analysis is done. And I mandate my pathologists, who I know very well, that they must document that CD30 was done and that there is no breast cancer, no lymphoma, no other squamous cell cancer, anything reportable, and that cultures are done for bacteria and fungus. Just like within the last 1 month, I have 2 patients where the candida was noted, and I sent those patients to infectious disease so they could get treated. I saw a posting where the surgeon looking at the implant said that this is fungus. No one can conclude that. The only way you can, because sometimes it may be dried up blood at the valve and you can think that this is black equals mold equals fungus and now you're getting treated. No, you have to find out what the species of the fungus is. You have to culture it and grow it and do it definitively. I cannot look at something, i.e. on an implant, and say that this is quote dried up blood or this is fungus, because it's not a diagnosis made by visualization. Now, if I see a loaf of bread in the back of the fridge that's been there for like 3 weeks and I see fungus, yeah, that is what it is. But you have to, as a surgeon, as a doctor, have objective evidence before you can treat basically a fungal infection. Now, the most important thing over here is your surgeon has to show, and this is the take-home message, your surgeon has to show that he or she removed the whole capsule and that he or she completely, sincerely, definitively, honestly, religiously believes into removing the capsule. Because I find in my practice, majority of the surgeons with their egos, unfortunately, believe that they can do the surgery. Now, when the going gets tough and they get tested and tried in the operating room and they have to remove that thin capsule, this surgeon was honorable enough to write, I cauterized the capsule. And the patient was still hurting 9 out of 10. Now, we will hear directly from her and see how she's improved. But if you go back and look and you go type in my Facebook page, residual capsules, you will see the many patients who have improved dramatically because that capsular burden was now permanently removed. And this is what is the take-home message. So across the country, you look at any explant surgeon, they're going to write down 100% total capsulectomy. And this is now overriding what the local plastic surgeon is saying. And you're seeing now the plastic surgeons are using this buzzword en bloc or the total capsulectomy because they know that this is what is being sought after, even though the FDA and the rest of the Plastic Surgery Society is denying the fact that a total capsulectomy must be done in every case. They're saying do a total capsulectomy if you have a BIALCL. If I did an en bloc on that patient that I mentioned with a 600 cc implant on the left that was ruptured, and I just removed the implant, that was going to be a ruptured implant silicone into her left chest with slime, i.e. the silicone bathing that entire left chest cavity with silicone. And now this patient would have been done disservice. So if you look at the Facebook Live I did last week with the 600 cc's ruptured implant, the en bloc Yes, it is not an exact term, it's an oncologic term, but 100% total capsulectomy without a break in that capsule was the exact surgery she needed, such that none of the silicone spilled into the chest. If there was any fluid, none of it spilled into the chest. All the badness was removed, and all what was removed was tested. So that lady has the peace of mind that there's no surprises awaiting her, and that she is free and minus all these symptoms of what is a ruptured implant. Now remember, there's a certain etiquette and finesse. Yes, it is a hard surgery, and if you ask me, if you're not determined, if you're not a firm believer in it, you're never going to do it. So I find a lot of patients. I have a patient actually right now, another patient from Arizona. I talked to her at the beginning of 2024, and she said, you know what, I found myself a local plastic surgeon, and I'm going to get an explant because I don't want to travel to Michigan. Guess what? She had her surgery in April of 2024. And then subsequently, she calls me back and says, hey, doc, I know you and I talked, but I'm feeling the same symptoms as I did as I had my implants. I want to come to you for residual capsulectomy. And you will see the patients. They know their body the best, and they will speak and they will say, I'm not the same. There's another plastic surgeon who did an explant right here locally, and she offered this patient a supposed end block. Now the patient post-op felt like $1,000,000. She felt great, and all of a sudden, a few weeks later, she felt the same BII symptoms as if she had implants. And deep down within her mind and her heart, she said, I know my surgeon did not do the whole capsule. That's how well the ladies know their bodies. Because she had this quote honeymoon period where she felt like $1,000,000. Some patients don't. Some patients feel great for some time, but then all of a sudden the symptoms come back, sometimes worse. I have another physician in the Pacific Coast who's likewise the same situation. I did a Facebook Live 6 weeks ago with another lady from California, and it's a patient after patient where they realize that do it right, do it once, do it with a surgeon who completely sincerely believes in doing it, such that you don't have to second guess your surgeon. And let's say if your surgery is done today, you have the peace of mind that all of the capsule is removed and all of it is tested. And that is the gist and heart of the surgery. Anyone can remove implants. It's all about the capsule, and not only the capsule, but the inflamed tissue. So go ahead and listen to my Facebook Live I did with a patient from Germany, where she already had her 2-time capsule removal attempt, and I was the third surgeon to finally ultimately remove. I did a Facebook Live with Cecily Henderson almost like 2 months ago, where you will hear her speak 6 months out, another patient from Switzerland, and many other patients. I have another patient signed up for another Facebook Live with residual capsule removal and how much better she felt thereafter. You cannot pick up on the residual capsule on a MRI, and the ultimate safest answer is that your surgeon is not augmenting. He or she believes in removal of the whole capsule done right the first time, and that your surgeon has a track record of removing residual capsule. Because I will tell you, the easiest surgery is where you have an implant capsule intact, and a small implant in a patient that's postmenopausal. The next one is where the implant is ruptured above 500, for example. The next level is a surgeon where he or she attempted to remove the capsule, and now he cauterized the capsule on top of the rib because that was an incomplete surgery. And now when I have to go back, I have to remove pieces of that wet tissue paper, that capsular inflamed tissue, and that is the hardest surgery for me. And this is a surgery, if you ask me, not many people would want to even think of doing, let alone doing it right the first time, because they're not believers in what is breast implant illness. And the vast majority of the surgeons, unfortunately, do not truly believe in it because they're still augmenting. How can someone augment and at the same time explant when there's two different surgeries that one is doing? Again, just trying to accommodate to all the patients, but compromising the explant surgery because they're not firm believers. Because remember, this is an involved surgery. It's not easy. If you look at the Board of Canadian Plastic Surgery, the American Plastic Surgery Community Society, European, they all are saying this is expensive. You bet, because no one's covering the cost. Number two, the they are saying that this is a dangerous surgery. Well, guess what? If someone has a pancreatic mass and they have to do like a Whipple procedure, that's dangerous surgery. Does it mean that you don't do it? No, you have to do the surgery. And that's why you have to do it in the manner that it is done, so that when you look back at it, you're not second guessing your surgeon. Another patient said, well, I'm going to go to my local surgeon. We'll see. Remove the implants, and I'm going to pay $0 out of my pocket. And now, if I still have symptoms, I'm going to come to Con. I will tell you that is not smart. What if the implant is ruptured and now there is spillage of the silicone inside the chest? What if, God forbid, that you feel good and that was 70% of it that you felt better, and you didn't realize the other 30% could have been met because your surgeon could have removed the rest of the capsule completely definitively, right? And so we find this whole gist of the surgery is about the capsule. And you type in explant surgeons, they always will talk about total capsulectomy. And within the textbook, there is no textbook that describes how the explant surgery needs to be done. It is literally on the job training. How many end blocks did I do in my training? 0. This is literally on the job, where now the patients are coming to their surgeons and saying, can you please do it? And the surgeon says, well, I will try my best. And now they have a track record of different varying. What is the most common answer? Well, it's not truly required. Oh, you are one of those people that are on social media and listening to other patients. Okay, I will do it because I don't want to lose my patient. And the next thing you know, that they're attempting to, and it's a thin capsule, just like that doc from last week who had her surgery done, and literally her surgeon felt that he or she did the best for the patient, where in reality the patient was doing disservice because it was an incomplete surgery. Now, the other thing I want to mention here is, remember, this is a surgery. I do 6 of these in a week. Remember, the one who is augmenting will do 6 of these augmentations in a day, because it's 45 minutes to an hour, and between 2 operating rooms, 3 and 3, you can easily do 6 in a day and have the rest of the week off. Remember, this is a surgery where it is mentally draining, physically draining. It hurts the neck and back because you're very focused right on top of the rib. There is a risk involved, absolutely, with the pneumothorax and other bleeding and whatnot else. And that it is a surgery where it has to be done with the heart, from the heart. And it has to be done with pure personal input from the surgeon, where he or she feels like they ran a marathon every single time the surgery is done. And I will tell you, not every surgeon can do this surgery because they're not sold on the fact, they don't believe in it. And if your heart's not in it, you're never going to do it. And your surgeon must be actively talking about. Your surgeon must be showing pictures and videos. So if you go to YouTube Shorts, you will see on the chest wall that there is complete removal of that fascia of the intercostal muscle, fascia of the periosteum, perichondrium, the fascia of the pectoralis minor and pectoralis major inferiorly, and the fascia of the serratus. So it's a complete cleanout. There is no second guessing your surgeon. That's your surgeon.
I do have another question
Yes,
from
please.
TikTok. Why are implants not banned?
Guess what? They were banned. And guess what? With the momentum we are in, if you look at the Google search engine, the number of surgeons who are now explanting across not only United States, Canada, in Europe and South America, we're certainly heading towards a ban. Hopefully the FDA will step up. Hopefully the plastic surgery community will step up and say, you know what? The hurt is so much, we don't need to look for a researchable answer that it is the this problem, or that is the culprit, that's the silicone or whatnot else. We already know about gel bleed. The FDA is telling you, I read it earlier. We're talking about silicone migration. Remember, this is a phenomenon where your body is recognizing the implants. The implants are basically hurting the body. The body is trying to fight this giant cell reaction, as you see in the many pathology reports. And you would think that someone would step up. Guess what? No one has stepped up and stopped the Juul cigarettes, the vaping. We know that's bad. Did they step up and stop the narcotic industry, where billions of dollars were given and used in interchange between the medical society, the doctors, the pharmaceutical, big pharma? And unfortunately, the patients are succumbing to these addictive personalities. And unfortunately, it's not the patients. The patients are the innocent victims in all of this. And so the bottom line here is, we want each and every one of you who was harmed and hurt to very nicely, assertively, professionally write, my implants did me disservice, and this is why the many patients say they wish they had never gotten implants. They wish they had gotten them removed sooner so they could have gotten their life back. And the bottom line is we're certainly heading towards it. If you benefited from the implants, write that you benefited. And I'll tell you just the fact alone where the black box warning says breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. And that on average, they last 10, 15 years. And they want you to get, the mentor, for example, they says they want you to get an MRI at year 3 and every 2 years onward to look for a silent rupture. It will come a time 2 years later. So this patient from last week that I did who had the residual capsules, she got implants in 2022. In 2024, she already got her explant and she knew within 2 weeks that they needed to be removed. So it can occur as soon as that. 2 weeks where the patient knew that they were not right for her body and that she was hurting. And she has a lot of other autoimmune problems. So talk and write about it. The FDA, unfortunately, is looking the other way. They're trying to please all these other political groups, surgeons who have gotten together, who got these approved in a very smart, cunning way. And look, the patients are hurting. And this wave of patients who got silicone implants in 2007 onward and now are coming with ruptures, problems, complications, and they're not lifetime devices for all these problems that I mentioned. And now we're dealing with this, unfortunately. So there will come a time, it is inevitable. And the answer here is it has happened before and history is repeating itself.
I have another question, Dr. Khan. Are there any signs and symptoms for extracapsular rupture? Is there any way you can visibly or palpably tell if a patient has this?
No, so that's why they say MRI screenings are done. So MRI is certainly better, more sensitive and specific when it comes to than ultrasound. They don't say go to a good board certified plastic surgeon. I have examined a lot of patients that had an excellent result. And when I went in and through the surgery to remove the implant, lo and behold, it was ruptured to my surprise. And so no one can detect, even if you get 1,000 plastic surgeons to examine someone, 1,000 of them will not say, oh, this is ruptured or not. There are plenty of times I've gone in thinking it's a grade 4 painful contracture and it looks abnormal and it was an intact implant. And there are plenty of times I've gone in and it was a 2016, just 9-year-old, 10-year-old set of implants, 5-year-old set of implants 2.5 months ago from 2020, it was ruptured, so no one can detect.
Another question. Let me get to it. Why are breast cancer patients given breast implants for reconstruction when they can cause further damage?
So this is a quote informed consent. You have to go ask your plastic surgeon who's working with the breast surgeons why that is the case. Unfortunately, I will say anecdotally, 90% of the patients who get breast cancer unfortunately end up getting implants for reconstruction, and unfortunately they're not told choice number one, flat chest. The implants are certainly very much sold to them thinking that these are very safe, that's the standard of care, you deserve the best. All the patients that I've talked to, they overwhelmingly say they were never told this, they're lifetime devices, that they can rupture, they can get gel bleed, not all. But remember, how do you know you're not that person? Remember, we didn't even talk about that very rare BIALCL, which is part of the black box warning. It's very rare of rare, but remember, there's squamous cell cancer, there are other leukemias, whatnot else. So another question.
So is muscle repair always part of the explant process?
So this is a very good question. I just saw a patient that came from Ohio, small lady, not big. She had 500 cc implants. Now you can imagine when the surgeon cut the muscle and put the 500, you have to cut the muscle very generously. And when they cut the muscle retracts. Now let me give you an analogy. If someone cuts the Achilles tendon, let's say accident, and the muscle is going to retract up. And now can you 3 months later take the Achilles tendon and re-implant it and basically reinsert it back to where it needs to go in the sole, the bone? No, you cannot. You have to elongate, you have to have a conduit. Same thing, when the muscle is cut, the muscle retracts up and the implant is there. So if this is the muscle, the surgeon makes the cut usually at the lower part, origin of the pectoralis, and now the implant is put underneath. And now the muscle window shades up. Now over time the implant moves down, and now the implant is removed. You cannot take this muscle and put it back. Now, as you will see, plenty of times I have repaired the muscle. I have shown pictures and videos where the surgeon was very smart, put in small implants. They went into the axilla, they didn't cut the muscle, and they put very reasonable size implants. So certainly muscle can be repaired, and I've absolutely repaired muscle, and the patients deserve it, not only for function but also for aesthetic reasons. Now, if someone cut that patient that I saw today, 500cc implant, and the muscle is window shaded up, you cannot take the muscle and reattach it all the way down, because it simply cannot be done. And so it depends on how how small the implant is, if it's ruptured, how the surgeon cut the muscle initially.
Okay, another question. Who do we write to about BII?
So the first thing you need to do is write to RFK, because he's the Secretary of Health. Number two, write to the FDA, because they have on their website anyone who's been harmed by any implants, and you can write a very you can actually log in and write your name, first name, last name, and you can if you go to my Facebook page, the Private Breast Implant Illness Support Group page, you will see the links as to what to do, and you can write. Now, if you've benefited from the implants, write that you want to thank them for doing an outstanding job. But if you've been harmed, tell them how you've been harmed, what has happened to you, that you thought that you were, quote, sold into, that these are very nice and safe devices. Write to them and go to the FDA page. When I called the FDA up, Dr. Corneliuson to be exact, she's an OBGYN doc, she was part of the implant. I do not know if she's still very much on. But she said, what are you talking about? We have not received many complaints. And I said, are you serious? Just go on Facebook and YouTube and Instagram and TikTok, or just Google and type in breast implant illness. Just look at the millions of patients all over the world, I use the word millions, who have joined these groups looking for answers, overriding their local plastic surgeons, and the explant rate has gone up exponentially. I said, if I were smart, I would jump in and take credit and say, you know what, we're going to start the augmentation process, because eventually we're going to look horrible in front of the world that we did not, i.e. the FDA did not listen to the patients, right? Because I don't think the plastic surgeons are going to step up and say that these are bad devices. Now remember, the bad is so bad, trust me, I would love to put in implants. I would instantly, and tomorrow, if I put in 6 implants and every other day 6, I would up my salary 3 times. My neck and back is going to be better. I would have, I don't play golf, but my golf swing would be so much good that I cannot tell you. This is, unfortunately, the FDA, the primary care doctors, the rheumatologists, the plastic surgeons, none of them are listening to the patients. Now the patients are taking this responsibility in their own hand and overriding the system and seeking plastic surgeons out who are doing, i.e. a total capsulectomy implant removal in the manner that it needs to be done. I had a plastic surgeon senior who said, why are you doing a total capsulectomy? I said, just go to my Facebook and just see my patients and see how happy they are, where if it's ruptured, I'm getting it all out. 4 weeks ago, today, I took care of an 89-year-old lady who had a catastrophe, i.e. in her right chest, and I didn't want to operate on the 89-year-old, but I want you to go see the Facebook Live. I believe this was the 16th or 14th of April, and I did a Facebook Live directly from the OR and how much this 89-year-old lady was hurting, and I did it to her as if she had like a ruptured appendix, and I did it to her because she was hurting, she couldn't sleep, she couldn't function, and this was overriding her quality of life, and I took the responsibility, and I'm glad I operated on her because she feels like wonderful. And I talked to her daughter yesterday, and she's going to be coming on, and she's going to explain her journey and her story, why after 1973, 52 years later, she got an explant, because her time was up and she was wanting to get this explant for a long time. So is there a reason why you don't do lifts? No, I will tell you. So this is very important. Today, anyone who uses the word lift, or any person who is doing and listening to me, please go to Facebook and YouTube, and I will post these pictures and videos. I want you to see where and how the cut is made around the nipple areola. and how the up and down cut the lollipop and how the excess skin mastopexy is done, and how the patients post-op mention that they have pins and needles feeling. Some patients cannot nurse. Some patients have hypertrophic, hypopigmented scars, painful scars, keloid type of scars, altered exam, altered mammogram. When they do their self-monthly breast exam, it's never the same. Unsightly scars. Yes, they may look young. It comes at a cost. In my practice, I would rather do another explant. So today, a patient came. I offered her lift. She didn't even ask me. I offered her lift because she already had a lift done previously, and she had the worst of scars around the nipple areola and down, and she had a mastopexy with her augmentation done 5 years ago. Her complaints were, I cannot feel this is another patient. She had pins and needles around the nipple. She had no sensation around the left. The right was pins and needle. She had very abnormal scars, irregular scars, and very unsightly scars present. And she said she wished she had never done a lift. And she's only 38. I will post some of these pictures. Now, I want you to go ahead and see what is the mastopexy, where exactly the incisions are made. And these are her own words. Had she known what a lift entails, she would never have done a lift according to her. And this is why should I do a surgery where a good number of the patients are not happy? Now, what I'm going to do is I'm going to start, let me just see, what are your thoughts about fat transfer? So I'm going to answer that question and I'll stop. If you look at how a mastopexy is done, where the cut is made around the nipple and down, and where the whole breast tissue is literally splayed open, and now the cut is made up and down in order to do an explant, you will be, I use the word horrified by the amount of dissection and cut that is made on a very sensitive area, especially where initially the augmentation was done through the inframammary crease. And you will see in majority of the patients, and they will not state it, but you will see what are the risks of getting a lift operation. You will see this, and I want you to do this. Till then, we will follow up. The second thing about fat grafting. So I promise you this week, I'm going to talk about a lift in detail. I'm going to show pictures and videos, and I'm going to do it such that you will see it on the monitor, and you're going to hear about me with objective evidence. Earlier so when it comes to fat grafting, so when you harvest the fat and you inject in the breast tissue, and you have to spread it out such that it splays open and it's spread out diffusely over the breast tissue, you will see a good part of the fat gets absorbed, and that's good volume. And the blood supply, the goal is to spread it out such that the blood vessels will incorporate and basically nourish and keep this fat alive that is transplanted from the belly into the breast tissue. A small amount of fat will inevitably die, and the body absorbs it because it's too liquefied. A small amount of the fat will inevitably form clumps of dead fat in and around the breast tissue. Now, I've seen patients from all walks of life that have come to me where they felt a mass and they said, is it fat necrosis? Is it a fat irregularity, hard nodule? Because of the fat transfer that didn't take completely, but the center part of it is dead. And now, even in the best of the best surgeons who have done fat grafting, this one patient came to me and they wanted to do a biopsy, but they did not want to do a biopsy because it was right in the proximity of the implant, because they were afraid to puncture the implant. And now the patient is getting very anxious. Is this breast cancer? Is this fat necrosis? And they want to do a biopsy. And now she said, can you remove the implant so I can get this biopsy to know if this is cancer or not? Now, this is happening. So remember, I started off this. There is a article that's out there, and this is true. I challenge anyone to say this. This was I was doing like basically board exam questions this weekend on a Saturday morning at 7 a.m. And this was one of the publications I read where 16% of the patients who get fat transfer, it messes up, alters, confuses the radiologist into thinking if this is breast cancer. It it basically alters the mammogram results. So now the patients are seeking more workup, ultrasound guided biopsy, maybe an MRI, maybe another 6-month follow-up. So it changes the mammogram. We're going to see the exact verbiage that this publication tells us. So it absolutely does that. Look at how many patients who have had BBL, which is a operation, which is the Brazilian butt lift, should be totally banned, because patients who have pins and needle sensation, it's never the same. And a self-monthly breast exam that is altered because of these quote nodularities, and plus the mammogram is thrown off because now there are irregularities that are picked up on the mammogram. That is 1 out of 6. So anyone who does, so I was sitting at a major conference, and here is the chief of plastics at a major hospital of the world sitting right next to me to my left. And I asked him, what is your opinion? And I know the answer. I said, what's your opinion about fat transfer on ladies? He smiles, he's like, the patients love it. And I said, how about this self-monthly breast exam and the mammogram? And you know what his answer was? The patients love it. And I said, what do you have to say about the physiologic effects of getting a fat transfer and the ultimate anxiety slash workup slash, he said, well, they can get it because this is a workup that is part of the known risks versus benefits. Now, I challenge anyone to tell me that fat grafting is benign and that it is completely void of any subsequent worries. And I'll tell you, it is a known established fact. And you can do the research yourself. There are many nurses who are following, many doctors who are right now listening, many plastic surgeons who are listening. And I'll end with this in a very humble, assertive way. I challenge any plastic surgeon to come on and we'll do a Facebook Live debate about the benefits of the implant, the ultimate benefits of the implant, breast implants, be it saline and silicone, and the harm and the hurt and the misery that they cause. And ultimately, you will see this momentum that is being set up is no joke. It is very serious. And it's not 1 or 2, it is thousands and hundreds of thousands of patients. And if you group together patients from all walks of life all over the world, you're looking at almost 35 million people who have implants, correct? And I'm not exaggerating. Now, will all get BII? No. Will all eventually get a rupture? Maybe they might succumb to a car accident and not get a rupture. Will they get autoimmune problems? And I'm going to read this. It says, patients receiving breast implants have reported a variety of systemic symptoms, such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. Now, they didn't talk about capsule. Breast implants are not considered lifetime devices, meaning sooner or later, your time will come, whatever it may be, and you will need to eventually remove, be it 53 year, the lady who had implants from 1973, 52 years later, and be it the physician that I took care of last week who had implants just 2 years and she was completely devastated by them, or the other lady in her 20s who had to have them removed on day 29 of her augmentation because her symptoms went through the roof. So hopefully that answers the question about fat transfer, and we're going to talk about it. We're going to talk about, so my next Facebook Live is going to be on fat transfers, specifically objective evidence. What is the literature talk about? And number 2, we're going to talk about lifts. I want every one of you to kind of do your own research, networking, to call a plastic surgeon up in board certified and ask him what are fat transfer, what are the risks versus benefits, and read up on this. And we're going to talk about lifts, so you can read up on that, so that when I talk, you will have some background information about these 2 procedures. So warm welcome to everyone. It's a pleasure to be on. Again, please ask questions. My job today is to read to you what you already should know. This is the labeling recommendations to improve patient communication. There is no, if you ask me, there is a poor job with patient communications. Most of the patients are very surprised when I tell them they're not lifetime devices. And I said, these are not my words. These are the words of the manufacturers themselves by the FDA. Do your homework, do the surgery right, do it once, do it with the confidence, And there's a lot of information we know where you can make a mental sound decision and a decision from your heart. And God will guide you about what to do next. And don't rush into the surgery. Know your risk versus benefits, just like you would undertake before you sign up for any surgery. This is Dr. Khan, Executive Plastic Surgery.